Hello everyone, it's the Fibroid Doc, Dr. Prabakar here, and hope you all had a great long weekend and got to do something fun and relaxing. Today I am going to be talking with Laurel Fertility. Dr. Smikle from there is going to join us shortly, just waiting for him, and we are going to talk a little bit more about fibroids and fertility, and how exactly fibroids cause infertility or reduce fertility. So really excited for that. I am just, yes, hi Dr. Smikle, you just have to request that you join the live, and then I can add you. And for anyone who's watching, please let us know where you're watching from. And if you're watching this later, please type hashtag replay.
Hi, how are you doing?
Hi there.
Wonderful meeting you in person.
Hi, I'm good. I know. So great to meet you. Thank you so much for joining this afternoon, and just waiting for people to join. Hi, everyone. Please let us know where you're watching from. If you do end up having questions as we chat, please drop them in the chat below, and we'll try to answer them in the next 30 minutes. And if you're watching this at a later time, just type in hashtag replay. And again, if you have questions, you can still type it in the chat later. So I have Dr. Smikle here from Laurel Fertility. If you can just introduce yourself and tell our audience a little bit about you and what you do.
Thank you for allowing us to join in. Definitely glad we're able to support you in any way. My name is Colin Smikle. I'm the medical director at Laurel Fertility Care. We have offices in San Francisco, Oakland, and the Central Valley. We've been around for about 17 or 18 years now, and have been providing care to patients from across the globe. And we've actually helped patients in terms of building their families in many ways. We care for individuals, same-sex couples, and basically parents who are choosing to build their families, or start their families. So it's been really helpful to talk to people, manage a lot of patients with fibroids as well. So thank you for allowing us to participate.
Yes, great. Well, that's a great mission, and you're spread out all over the Bay Area. And we'll get a little more details about that at the end. But let's dive into fibroids. For those who are watching, I am a board-certified gynecologist, and I'm a minimally invasive surgeon. So I take care of a lot of women with fibroids in the OR, but just also in the office who are having symptoms. And one of the biggest things I see is, women with fibroids then not being able to get pregnant. And then I end up referring them to infertility doctors. But a lot of times it also goes the other way when I get referrals from infertility doctors for, patients who are having fibroids, who are having trouble conceiving. So I'm wondering if you could break it down for us and talk about what is it exactly about fibroids that cause reduced fertility or have couples, having trouble conceiving?
First of all, as you know, many patients will have fibroids. It's more common, say, in African American, Asian communities, but about a third of women will have fibroids of all kinds. The ones that are primarily going to interfere with, or at least impact pregnancies, are ones that are primarily related within the cavity itself. So whether it be intracavitary fibroids that are going to block implantation itself, intramural fibroids are going to impact and reduce the volume of the uterine cavity, or subserosal fibroids that are going to obstruct the fallopian tubes. Those are primarily the ways that fibroids can actually impact fertility. Many patients will have fibroids, and if they're not in those areas, then although it may be uncomfortable while pregnant and they can grow while pregnant, they're not going to interfere in the same way. But when it's basically involving the places where implantation occurs, then you may end up impacting infertility in terms of either preventing pregnancies in general or getting pregnant and then actually miscarrying, which is the other complication.
Right. Right. Okay. So if you're just joining us, we're talking about fibroids and fertility. And just to go back a little bit, fibroids are benign tumors of the uterus, and they can grow inside the cavity, they can grow in the wall, they can grow on the outside. And depending on how big they are and where exactly they're located, they can actually cause reduced fertility, as we just discussed. So now, as a fertility doctor, where in the process are you encountering women with fibroids? Are they already coming to you knowing that they have fibroids, or are you ending up diagnosing fibroids for the first time?
Well,
Tell us a
a
little bit
lot of
about that.
patients are coming in, and it all depends on where they are in their fertility journey. Now, a lot of patients are coming in, not even planning to get pregnant now, but basically considering, their chances for the future, and are either interested in egg or embryo cryopreservation. And those individuals, they may not even know they have fibroids. They haven't seen a gynecologist in some time, or if they have, they may not have known the size and the impact of the fibroids. So they're hearing it for the first time because, most times when we're actually talking about things and doing an examination, it's going to involve having a transvaginal ultrasound. That allows us to see the uterus more clearly and allows us to identify fibroids more precisely. And then we can kind of talk about in the relative role in terms of how it may impact their being able to conceive. In those individuals who are trying to delay pregnancy, what I'll also often advise is just that it may not be relevant or important to try to fix those fibroids or take care of those fibroids if they're going to impact things, unless they're going to have symptoms, and that's a different scenario. Because, as you know, and you can describe, sometimes going through and operating for fibroids, they recur, and they may actually cause other issues like scarring. So we want to try to reduce that impact as well.
Yes. Yes. You mentioned egg freezing. So just as a little quick aside, are you seeing more and more women now coming in for egg freezing? And if you can just give us, a 2-minute spiel on what your advice on egg freezing is in terms of the age, because that's something that patients are asking me all the time. Like, am I too early? Am I too late? Like, can I go and freeze my eggs now? Especially those who have really bad fibroids, who then know that they're not going to be able to carry, but maybe their friend or their partner is going to carry.
That's a great question. And I think, the key thing is just that, in the Bay Area, we've been very fortunate in terms of having a lot of technology companies that are actually helping their employees and affording the opportunity to preserve the opportunity for the future. So a lot of women are coming in basically interested in terms of egg freezing. The key things in terms of, there's a great paper that was done probably now about 2 or 3 years ago, published by American Society of Reproductive Medicine, Fertility and Sterility, that talks about the age for freezing eggs versus freezing embryos. We know that in many women who are, say, less than 27, 28, they have some time before they make these decisions, because most times when you're freezing eggs, people are going to make decisions within the next 3 to 5 years in terms of using those eggs. So if someone who's, say, less than 27, basically 5 years take them to 32, so therefore their chance of success may not diminish over that time period, unless you do some testing, some screening tests, and we find out that they have diminished reserve, and therefore those individuals are encouraged to basically preserve their eggs or embryos a lot earlier, because they're going to run out of time earlier. So going back to the question of typically when, I'd say the typical age is from 27, 28 to 35, 36 for creating eggs and freezing eggs. After that time, the number of mature eggs that are actually going to be abnormal may increase, so therefore women who are over 35 may start considering freezing embryos instead. Freezing embryos allows you more information about the embryos themselves, because you can actually go as far as actually getting information about the genetics of the embryos, making sure that embryos are genetically normal, and therefore that's going to impact implantation. The more normal embryos you have, the higher the chance you're going to be successful. Under age 35, many of the eggs are going to be good, so therefore you can still freeze eggs themselves, realizing that you'll end up having some normal ones in the future. And the typical guideline in terms of how many is that it depends on what your goals are in terms of having a family. So someone, say, less than 35, you're going to end up having 7 to 10 eggs per planned pregnancy. So if you're thinking about having 2 children, you may think about having 20 or more eggs to freeze. And if you're thinking about having, a large family, say, so there's some individual who still want to have, say, 3 or 4 children, then you're talking about having 40 or 50 mature eggs frozen so you can actually maximize the chance you'll be successful. Many times you'll end up having more eggs than you need, but again, because we don't know about the genetics of the embryos that are going to be created, we want to have you end up having a better opportunity by having more eggs available. Embryos, you'll know more, so you'll actually just get the ones that you need. And that's primarily the thing to think about.
Great, that's such good information. And I mean, I think just discussion of this makes me think like how much you sort of have to plan these days, right? I mean, it's lucky that, as you said, we live in the Bay Area where, if you do end up having infertility issues, a lot of the companies now are paying for these services, but for most women across the country, that's not really the case. And this, we're running into tens and thousands of dollars for by the time you do the egg freezing, and then if you have to do IVF and all of that. So I know one of the things that I'm telling patients, in the early 20s is really to start thinking about fertility, what their plans are, and also getting a family history. A lot of women have no idea, like, if their mom had any medical issues or grandmother, and especially when it comes to fibroids, we see that it runs, in families. And I bet people ask you this question all the time, and I'm curious to see what you say is, like, well, why do I have these fibroids? I'm 26 and I'm trying to get pregnant, and nobody's in my family's ever said anything. But what do you say to that patient who says, like, why am I having these fibroids?
Well, that's a great question, and I think the easiest way to think about it, or basically explain it, is just that most times you've had them all along. It's not something that you can. It's not a disease you get. It's not something you have any control over. And many times you may not even know that you have it because it's something that grows slowly over time. So therefore, you may end up not even knowing that you have it or realizing there's a fullness when you're actually, especially around the time of your menstrual cycles, because you end up having these fibroids that grow, or at least may create that fullness. Or some patients will end up having it protrude and in fact, their bladder capacity, so they may end up noting they're going to the bathroom more frequently. And so those are the questions that they may come in, and they probably come to ask you those questions more than they ask me, only because essentially when they're asking you, they're asking more directly, how do you get these fibroids, and how does that impact, just in terms of their lifestyle? Whereas in terms of when they're coming to see me, they may actually be hearing for the first time that they have fibroids, and they're asking, so how can I take care of it? And then that's a different conversation in terms of basically trying to walk through and explain to them what's going to be the best course of action to take.
Right. Now, when it comes to the best course of action to take, for fibroids and fertility, so say a 30-year-old woman comes to you, she's got fibroids, and maybe they're some are inside the cavity, some are in the wall, but in your opinion, it's definitely going to cause an issue with her getting pregnant. What are some of the things you suggest in terms of treatment? I know I have my own counseling for patients, but patients are so interested in, like, well, what can I do naturally to get rid of these fibroids, or what next? Like, if I want to get pregnant in the next 2 years and I have these 3 big fibroids, how do you counsel somebody on what the next steps are in terms of treatment that they need to be thinking
That's
about?
a great question, and I think the biggest and most important thing is simply to say, having some sort of surgical procedure to remove the fibroids and reduce the impact on the cavity, because that's where I'm most interested in, is going to be important one. Several years ago, there was a lot of different ways in terms of management for fibroids. People used to end up having basically what they call myolysis, where you go through and either surgically or using radiofrequency dissolve the fibroids. In my mind and in my experience, that creates a lot of adhesions and a lot of contractions within the uterus. And you'll end up having someone who, yes, it's true, you may shrink the fibroids without quote unquote doing surgery, but it also reduces the uterus's ability to then, regrow and restructure with pregnancy. So those patients are going to end up having far more complications than someone who basically had surgically removal of the fibroids. So for me, I'm always referring patients to someone like you who are going to do the surgery rather than say to a radiologist who are going to do the radiofrequency or the ablation. Because basically any procedures that cause either, some ablative action for the uterus causes more scar tissue and creates more problems. And if you have fibroids and you end up having surgery, there's several things you can overcome. If you have an ablation and the fibroid, the capacity for the uterus to stretch and grow and basically perform its function that normally would occur with pregnancy, if you remove that function, then the only option the patient has is to go through and using a gestational carrier in order to build their families. And very few people even think about or want to consider that as an option. They're more likely and more inclined to basically consider using their own, having a carrier themselves. So that's what I'd advise them to do.
Yes, I love that you said that, because there are so many patients who are scared of surgery. They want to get pregnant, but they want to try all the other things that don't involve surgery. But when it comes to fertility, as you said, surgery is one of the cleanest options. You open the muscle, you take the fibroid out, you suture it back up, and then you let it kind of restructure and regrow, versus a lot of these other ablative procedures are actually end up with more scarring. So in the long term, it seems invasive. In the short term, it seems invasive, but in the long term, you actually end up getting better fertility benefits and outcomes. So so bouncing off of that topic, another thing patients ask me all the time is, okay, now that you've done my fibroid removal, when can I get pregnant? And I know there's some mixed data about this, but as a fertility specialist,
well, I think it depends on where the fibroid was in the first place. So if it's just inside the cavity and you're removing those and the rest of the uterus is normal and you're not really either impacting and you're not going through the wall of the uterus or cutting into the uterus itself, those patients can actually get pregnant pretty quickly and without really much downtime. So, you can easily go from surgery 1 month to trying the next month. The more invasive it is in terms of the more, if there is, restructuring of the uterus, that's where you'll end up having some changes that occur. And anything that basically, what I would imagine goes through at least a third to a half of the impact of the cavity may end up causing more a weakening of that area where the fibroid was removed. So those patients may end up having a longer recovery. So in the typical range, it goes from, trying as early as the next month to at least waiting 3 or 4 months before they try to conceive, because the more, removed fibroids are removed, you do need to have those muscles realign, that tissue heal. So therefore, there's a lot lower risk for actually having, the pregnancy that, allows the uterus to grow, also causes the uterus to basically rupture. And that's one thing you want to try to avoid.
Yeah. Yeah. Okay. So I'll also add that depending on the extent of the surgery, a lot of times your surgeon may say that you actually need a C-section, instead of a normal vaginal delivery, and you may want to do it a little bit ahead of time too, right? 37 weeks, 36 weeks even, for the same reason you mentioned. We want to avoid the uterus rupturing. Yes. So this question does not have directly to do with fibroids, but somebody asked here, what about people with oligospermia? What kind of fertility options do people with oligospermia have? If you can talk to us.
Definitely a different transition from, basically talking about fibroids and male fertility, but I think the key thing, it depends on what's the cause of that oligospermia. Oligospermia means that there's actually a lower sperm number, and it may also relate to lower sperm count and function as well. And there are several factors related to that. It may be related to end up having the men having what's called varicoceles, blood vessels that are next to the testicle that lower the count and may actually affect motility. Or it may be, something either genetic, so therefore, they end up having, really low counts. It could also be environmental, so therefore a lot of it has to do with basically getting the history and then finding out, are there ways to kind of overcome that. Women are born with all the eggs they have. Men make sperm every day. So even though you end up having someone who may end up having oligospermia today, if you can identify the cause, you may be able to increase the count, motility, and morphology sufficiently so they can actually function, depending on where they're starting. If it's significant, they may not have many other choices and other than going through in vitro fertilization and then doing an additional procedure called ICSI or intracytoplasmic sperm injection to fertilize those eggs. But, that all depends on the severity, the patient's age, the partner's age, because, that's actually where things are going to be impacted. So, it depends on the long answer is it just depends on the actual cause itself.
It depends. Yeah. Okay, great. Thank you for answering that. I don't see any other questions here. So kind of going back to fibroids, are there any other things that you think, we've talked about sort of how fibroids are diagnosed. We talked about some surgical options. We talked about what fibroids are and how they cause infertility. Anything else that you think is important to let our viewers know, when it comes to fibroids and fertility?
Well, I think the question that often comes up on patients ask is that, is there things, and you address this in a bit in terms of, are there things that I can do to fix the fibroids? And the answer to that, unfortunately, is no. It's not something that kind of goes away. Is there something that, you can do other than surgery to reduce the size of the fibroids? There are some clinical studies to show that you can take some medicine to shrink the fibroids. They may act by, basically, causing you to kind of go through somewhat of a menopausal transition for the short term to basically allow the fibroid to kind of go. That may be helpful, but sometimes what will end up happening is that it changes a fibroid from being one that's in the wall to pushing it into the cavity. So it may reduce the type of surgery that's needed and also, make this surgery less severe. But, I think it all depends in terms of location. Like real estate, basically fibroids act the same way. Yeah. It's location, location, location. So that's important to know.
That's right. That's right. We live in the Bay Area, so we really understand that. Right. Great. So, this has been really helpful. I hope everyone who's been watching and who will watch and listen to this later, is finding this helpful. Where can patients find you? Say there's a patient here who's like, I really need some help with egg freezing. I have some questions about IVF. I'm 40. I'm wondering if I can still have kids, and they want a fertility specialist. Where can patients find you, and what kind of care
Well,
can they
I think
expect?
the important thing is my partner, Dr. Prabakar, and I are board-certified endocrinologists who basically, this is what we do. This is our passion. So we are a small practice that basically provide more individualized care. And so patients can basically find us either in the Bay Area. We see people from around the world. So telehealth allows us to kind of provide that service. And, the important thing is we provide care from intrauterine insemination all the way up to IVF, ICSI, gestational surrogacy, egg donation. We care for a lot of same-sex couples who are basically either female couples providing eggs for their partners or male couples using a gestational carrier. So we offer the breadth of services. People can reach us at www.laurelfertility.com, and we'll be happy to help and address any questions you have.
Great, great. And I know that you also have a lot of educational and support services for patients on various topics, because it's a very emotionally trying time for many as they go through this process, and a lot of hope, sometimes failure, and ups and downs. And so I love that your practice provides those webinars and a lot of extra support. So great. Well, so glad to have had you on here. And for anyone listening, laurelfertility.com. And is that right?
LaurelFertility.com. That's
Laurelfertility,
correct. So yes.
laurelfertility.com or laurelfertility.com? Okay, perfect. All right. Well, thank you so much for joining us, and we'll hope to see you
And
live in person
thank you for the
soon.
invitation, and definitely looking forward to seeing you live in person. Okay. Okay then. All right.
All
Bye
right.
bye now.
Take care. Bye. Bye.